cervical node, and this is an unusual site actually, tonsil, but many cases have been reported in the literature. Other sites are GIT, omentum, liver, mesentery, oral cavity, spleen, lungs and breast. And it has got a very peculiar nature of distant metastasis to the liver and lungs, unlikely of a lymphoma. And the pattern of spread is that of a soft tissue sarcoma and not of a lymphoma, though it arises from a lymphoid structure. It requires a very high index of suspicion. It's aggressive neoplasm of intermediate grade, but it's generally unresponsive to conventional therapy and leads to widespread disease. Though it is said in the literature that it's a intermediate grade, but the 50% mortality they quote is almost, after 5 years the mortality rate is almost 50%. And the treatment strategy is mostly combined surgery plus chemotherapy plus radiotherapy. Even after that the patient don't come out well of this disease. The ISC pattern normally sees CD21 because CD20 was not available, so the other alternative for CD21 is CD23. So CD23 was done, and the other markers which are positive in a dendritic follicular cell sarcoma is CD35, KIMP4 and KFD-RC1P. These are proliferation markers. And the tumor cells are negative or equivocal for CD45RB, and constantly positive for S100. And frozen sections can be stained for dendritic follicular cell marker like R423, SLA-DR, lymphocyte adhesion markers. These are not used much though. Now this is a neoplasm of the accessory immune system, antigen presenting or dendritic cells. These occur primarily in the lymph nodes and are also reported in a variety of other extranodal sites. A small proportion of cases arising against a background of Castleman's disease, which is a lymphoid pre-malignant lesion of the lymph nodes of the hyaline vascular type, and others in association with Epstein-Barr virus. So there is supposed to be a infective origin also. This is a picture of Castleman's disease, hyaline vascular type. The other tumors, this is the first tumor we spoke about, dendritic follicular cells. The other tumors which can give rise to sarcoma sort of presentation in a lymph node or other structures are interdigitating dendritic cells which look almost similar to dendritic follicular cells, except that there is more pleomorphism. And these are negative for CD21, 23. Then Langerhans cells, fibroblastic reticulum cells, macrophages, sinus lining cells or littoral cells. So this is a chart of, this is a table actually of all the markers which is usually done when you suspect a case of either sarcoma in a lymph node, histostatic sarcoma, or a Langerhans cell sarcoma, or a interdigitating cell sarcoma, or a follicular dendritic cell sarcoma. Now coming to case number 2, this is also a very interesting case actually. 18-year-old female presented with a circumscribed breast lump of 6 months duration, which was clinically thought to be that of a fibroadenoma. Lumpectomy was done, and the gross we received was that of a fibrofatty tissue measuring 5 into 4 into 3 centimeters. One of the surface was multinodular, shows multiple small nodules actually, and the cut section was solid, homogeneous and firm. This is the gross received, and this shows the nodules actually, small nodules were there on one of the surface. And the microscopy showed single cell neoplastic cells in single cell as well as Indian file pattern. They had a concentric or pagetoid fashion around the ducts and lobules, mostly around the ducts. There was no gland formation, and the stroma was dense and fibrotic, and there was periductal elastosis. You can see the targeted pattern over here. This is a duct showing arrangement of neoplastic cells in a target-like pattern around the ducts. And this is the picture of Indian file pattern. This is the Indian file pattern we got. The cells, now coming to the cellular features, the cells were small and uniform, and they were disc cohesive, and the mitosis was quite scanty. and there is elastocyst, periductular and perivenous elastocyst. Any diagnosis from the audience?
External carcinoma.
No, sir.
No.
No. It's a carcinoma, but not ductal carcinoma. We thought of two possibilities. Either it could be a lymphoma because of the discrete cells, discohesive cells. Other diagnosis could be a carcinoma. But because of targeted pattern, single file arrangement, we gave the diagnosis infiltrating lobular carcinoma, classical type. A differential diagnosis comes as infiltrating ductal carcinoma only. It occurs in 4th to 5th decade. This is 10% of the breast carcinomas, and because she was very young female, 18 years, it's quite rare, quite unusual to have infiltrating lobular carcinoma in a young age, such a young age. And usually there is no palpable mass. It is bilateral, multifocal, and multicentric. So the prognosis becomes a little bit difficult for the surgeon to remove all the tumors. And it's more likely to metastasize to the GIT and the ovary. And the prognosis, as some of the books mention, is better than IDC, but the literature says that the same as that of IDC stage by stage. It depends only on the stage. And the lymph node metastases are difficult to diagnose because the cells are very small and they are discohesive. So they almost look like lymphoid cells. And the mammogram is not always conclusive because there is not much calcification over here. UHG is a better diagnosis, but the best they say is best MRI. But the biopsy, needless to say, is the final say in these cases. Treatment is surgery, chemotherapy, and radiotherapy. If the tumor is big, large, and there is lymph node metastasis, then you have to go for all the modalities. Otherwise, a wide extent usually suffices. The other variant, this was the classical type of ILC. The other variant we get is pleomorphic type, histiocytoid type, signet ring type, tubular lobular type. And this is a picture, just to show a picture taken from a book. This is the signet ring type.